record. Hello and good afternoon. My name is Kelly Brandt. I am a nurse practitioner for the Marshfield Clinic in central Wisconsin, and I have been a nurse practitioner for about, well, more than 10 years now, and primarily in neurology and specifically in movement disorders for the past 5 years. So today I want to share something with you all about pretty basic in some ways, but I'm hoping that we can get some pearls and some tips so that you are feeling more confident in when people come to you and with tremor, whether or not they have a neurodegenerative brain disease or whether they're dealing with just tremor. So let me see if I can figure out how to move this thing. Okay, so the intended audience is NPs or PAs basically in neuroland. However, I also think this would be very valuable for anyone in primary care when people are complaining of tremor and noting whether or not you can try to manage this yourself or whether they really need to be referred on to specialty services. No disclosures. So again, my educational goals by the end of this lecture, I'm hoping that you will be more confident in identifying the common characteristics of ET versus PD, identifying your differentials, and be successful in getting a meaningful history and a good exam. Do I have Parkinson's disease? This is what people come to me and ask. They say, I have tremor. I don't want it to be PD. Okay. So in order to help make sure that I'm giving people good information, I want to get a good, thorough history, family history, medication history, current and past. It is certainly relevant if they have depression, if they've been on dopamine antagonists in the past, dopamine blockers, what psychiatric care they've had, what environmental exposures they've had. We'll talk about some of the VA, well, Camp Lejeune and Marine Base and Parkinson's disease, any drug history they've had, head trauma, etc. All of these things are relevant to their neurological history, and examine. If you work in neuro, you understand that there aren't a lot of diagnostic tests for things, and these are clinical diagnoses. So you have to examine your patient. And some of these things we'll talk about today are pretty by the book, right? I'm going to talk a lot about what the book says, but when they don't fit that book, dig further, and then you're going to get labs, you're going to get imaging, but a lot of times you don't really need it. Okay, but you may find that reassessment is necessary because they don't really fit, but then all your diagnostics look okay. You might just have to see them back, and that's totally okay. Starting with essential tremor, this is what the definition is: nervous system, involuntary, rhythmic shaking. We're really dealing with a brain signaling issue. Your exclusion is really going to make sure that they don't have any other neurologic signs or symptoms. Most commonly, you're going to deal with both hands or their head, sometimes their voice, not necessarily their legs as much. We can call this many things: familial tremor, benign essential tremor, benign familial tremor, ET. We're all talking about the same thing. We're talking about a brain signaling issue that truly is tremor is the problem. Moderate frequency rhythmic oscillations means almost nothing to me, except when you look at a Parkinsonian tremor versus an essential tremor, you're going to be seeing Parkinson's being a slower oscillation frequency. Most often you're dealing with two hands, both equal. Okay, begins gradually. People don't come to you and say, yesterday I didn't have a tremor, today I have a tremor. People will say, gosh, I don't know, 3-5 years. Oh no, I still had it when I was working back in 1996. Well, they've had tremor for decades at that point, okay? Mild or absent at rest is very important most of the time. Now, there are people that I have that do have essential tremor. They have brain stimulators. They've had tremor for decades. They do have a resting component, but the people that are going to come to you for diagnosis really should not have a resting component. Tremor is very volatile, so it's going to be aggravated if they're stressed, tired, angry, sick. Their tremor will be worse. Again, we do not have a diagnostic test. I can't do an MRI and tell you you have essential tremor. So it is really important that we do a good history, a good examination. We rule out secondary causes, rule out medication. One thing I always ask is, does alcohol help the tremor? Some people don't drink, so they don't know, and the people that drink might not have noticed. Some people very clearly, they will say to you, yeah, if I have just a couple beers, it goes away. So, I always drink beer. Well, that's not a good treatment. Archimedes spiral we'll talk about. Handwriting test is also really helpful. So, here we go, Archimedes spiral. So on the right here, you'll see something I would have drawn, Archimedes spiral. And then on the left is a classic essential tremor spiral. So you can actually see their tremor in their handwriting. Again, your normal control up on the top. And sometimes people, they literally can't even get the pen onto the paper. Like you'll see them like struggling, okay? Because as they get closer to that target, their tremor will get worse. So inclusion criteria, things that support a diagnosis of ET, bilateral, postural, kinetic. So postural is this, posture, right? So you'll see the tremor, it'll when their arms are extended. Typically, if you don't see it with their arms extended, you can pull it out in a couple different ways. But kinetic tremor, finger to nose. We're looking at cerebellar function here with finger to nose, and you shouldn't see ataxia, although some people with severe essential tremor will look almost ataxic as they approach their nose, but as they get closer, their tremor might get worse. So I have them do a lot. I have them do a lot of finger to nose. It's persistent and visible and not distractible. So you have to be a keen observer in trying to get the tremor in their natural state. People want to perform for you. People want to show you their tremor, but you don't want to see what they think it looks like. You want to see their tremor. Sometimes people have a midline tremor, in absence of the abnormal posturing is you don't have a twist. You don't have a twist or a tilt with the tremor. So it's just straight up midline. Sometimes it's nodding. Sometimes it's no. Sometimes, well, depends. But if you see a twist or a tilt, then we're really looking at a cervical dystonia rather than a straight up tremor. In essential tremor, tremor is the disease. So if you have other things, it's probably not just essential tremor. So if they're sick, if they have end-stage renal disease, if they're hypoglycemic, if they're withdrawing from alcohol, if they have, a brain tumor, then those would be excluding the idea that this is an essential tremor. If they have an isolated vocal tremor, I would have high suspicion for vocal dystonia. Sometimes people will have a task-specific dystonia, and I like to listen for words like my arm will twist when I write. Or I saw one patient who only had tremor when he was playing pool, which was a problem because he was a professional pool player. But he had a very specific posture that he could get himself into that would bring out his tremor. But again, that's highly suspicious of more of a dystonia rather than an essential tremor. So every patient that comes in to me asking about their tremor, we ask all of these questions. Where is this tremor? Where did it start? Does alcohol or caffeine affect? Again, with ET, you'll expect that alcohol should suppress the tremor somewhat, and caffeine may irritate it. What activities are affected? So everybody's going to say their handwriting, but can they keep soup on their spoon? Are they having any trouble getting their zippers zipped and their buttons buttoned? Have they been sick? Again, we're looking at secondary sources here. There is a genetic component, and does the tremor bother you will lead us into treatment or not. When you examine a patient with tremor, we are trying to prove what we think it is, but also rule out what we don't want it to be, or what we're trying to exclude secondary sources. So postural, kinetic, you can have them hold a piece of paper. If their tremor is really fine, you may not be able to see it on posture, but if they hold a piece of paper, then they'll bring it out. I have people go like this and, not touch the fingers, but get close, because as they try to get close, their tremor will get worse, but they don't want it to touch. Pouring cup to cup has been really helpful to me too, especially for those tremors that seem like on posture that they're really not there. But if you have them pour cup to cup, you'll definitely see their tremor. Differential diagnosis. Most people, their primary has checked their thyroid. If you're doing outpatient therapy, they're hopefully not going to be an alcohol withdrawal. And I haven't had a consult where excessive caffeine was their, only issue. Drugs are a big issue, big, hairy deal. Almost everybody has some sort of mood disorder or that seizure meds. They're on Depakote, they're on lamotrigine, they're on bupropion, they're on amiodarone for their heart. All of these drugs, there's so many that can cause a drug-induced tremor. Pheochromocytoma and Wilson's disease are also can contribute to tremor, but these are the zebras here. This is not considered a neurodegenerative disease. It's considered a brain signaling disease, and hence not treating is perfectly appropriate, especially if the tremor is not disabling to them. So pearls to remember, basically everything we've talked about thus far. You're looking to be both hands, possibly their head. Legs would make me think maybe something else. We're looking at postural and kinetic tremor. There should be minimal, if at all, resting component. So we're looking at tremor being the disease, not a symptom of the disease. Treatments vary, right? Depending on the severity, depending on if they're an electrician and they really need to use a screwdriver. And this could be a whole lecture in and of itself, okay? There's a new thing out called Cala Trio for people who have a very task-specific essential tremor, or they just need like 45 minutes a day to get done what they really need to get done, and it seems to be helpful. Parkinson's disease is a much bigger, hairier deal, as they would say. We're looking at a disease where tremor is a symptom, but not the problem. We're dealing with degeneration of a deep part of the brain called the substantia nigra pars compacta. And we're losing dopamine neurons, we're losing dopamine transport. And if we oversimplify it, we just don't have enough dopamine. There are obviously other neurotransmitters involved, but we focus a lot on the dopamine. And this degeneration of the brain causes basal ganglia dysfunction, and you end up having a hypo or stiff, slow, hypokinetic movement disorder. Tremor is a symptom of the disease, but is rarely the most disabling part of the disease. If you have someone with tremor as their predominant and really only disabling part of their Parkinson's disease, they're going to do really well with time. I like this as a diagnostic pearl because when you try people on levodopa, they should get better. Okay, the vast majority of people with Parkinson's disease will be levodopa responsive. And if they're not, I always wonder, am I really treating Parkinson's disease, or is it something else? Is it an atypical Parkinsonism? Is it NPH? Is it a drug induced? Are they just burned out psychiatrically and they have Parkinsonism? Disease of the basal ganglia is complicated. If you've ever done if you remember pathophysiology, the basal ganglia is a very complex loop, but we end up with impairment in automatic execution of learned motor plans. We have involuntary movements, which leads to the tremor, but we also have muscle rigidity, immobility, and a whole bunch of non-motor symptoms. There are a lot of complex mood, cognitive, and behavioral factors in Parkinson's disease. If we look at motor symptoms, we're looking stiff, slow, tremor, and gait instability. But there are so many more non-motor symptoms: constipation, mood changes, anxiety, depression, cognitive disability, visual spatial dysfunction, constipation, if I haven't mentioned that already, REM sleep behavior disorder, etc. Differential diagnosis is you're looking, is this ET, is this PD, or is this one of those atypical things, okay? PSP, MSA, CBD, LBD can all mimic Parkinson's disease. And hopefully I'll give you some tips on how to maybe think, maybe this is an atypical disease versus a idiopathic Parkinson's disease. We do have these long list of zebras, as I'll call them. Wilson's disease, I would be suspicious of if they're very young. Huntington's, I rarely see a first generation Huntington's, but I have. But though I'd be looking at more of choreiform type movements stereotypically. Are they ataxic? Again, that looks a little bit different. Hydrocephalus, NPH. I just saw a guy actually this week who really does look Parkinsonian, and his big issue is freezing with his gait, but he is not levodopa responsive, and we're now working him up more for NPH versus idiopathic Parkinson's disease. History taking, again, I ask all of my patients who come in with presumed Parkinson's disease or evaluation for Parkinson's disease these questions: any issues with fine motor skills? Are you slowing down? Are you having trouble with balance? Usually people attribute their slowing down to getting older. Yeah, I'm stiff and slow. I've got aches everywhere. I'm getting old. I'm 75 now, but what is normal aging and what is PD is really careful history and examination. Usually people have lost their smell way before COVID. So it's a funny question now because we ask all of our COVID screening in these patients, but most of these patients haven't smelled for years. Trouble rolling over in bed is a really good question to ask because people get stiff and slow and then they can't roll over in bed. But they won't say, oh, I can't roll over in bed. They'll say, oh, I get stuck in the linens, or it's like the sheets are too tight or too stiff and they just want to loosen them up. REM sleep behavior disorder is also a huge key to ask every single patient, because if they are acting out their dreams, oh yeah, I've always talked in my sleep, or he'll scream or he'll kick or he'll punch, that is felt to be a risk factor and possibly a symptom of early PD. Any changes in handwriting. So people will start writing and then they'll write and it'll go up on them, or they'll start writing and then it'll get smaller and smaller and smaller until it's now all of a sudden illegible. Facial expression is tough, but there is a look. It's like you open the door and yep, they have PD. There's a look. Their eyes are a little more open. Their mouth might be agape. They have a masked face, as the books would call it. Sometimes they have voice changes too, the softer, or oh, my wife can't hear me. Well, is she deaf, or are you really just not talking loud enough? And again, we talked about, I mentioned this earlier, numerous non-motor symptoms: constipation, apathy, mood changes, intense or vivid dreams, many, many more. Flags for atypical Parkinsonism. If they have early hallucinations, so people, everybody knows Parkinson's patients hallucinate, but that's late in disease. But if they're hallucinating at presentation, might be Lewy body. Okay. Multiple autonomic complaints. They can't get an erection. They can't pee. Their urgency, frequency, sweating inappropriately, intolerant to heat or cold. They're super constipated. They have orthostatic intolerance. They're dizzy. They're passing out. They want to pass out after they eat, etc. I'm thinking MSA. Early and frequent falling or severe postural instability is suggestive of PSP. Progressive supranuclear palsy, the examination finding is inability to move your eyes upward, right? Supranuclear, but that's later. But if they come in and they're falling, then I think PSP. Or it just won't do what I want it to do. Or alien limb phenomenon we see with corticobasilar degeneration. So if we look at the diagnostic criteria for neurodegenerative Parkinsonism, idiopathic Parkinson's disease, number one, you have to have bradykinesia, slow. They have to be slow. And if they're not slow, you can't diagnose them with PD, okay? So this is where we get to number two, and they must have rigidity and or a tremor. So rigidity is resistance to passive movement. All of our books in school talked about cogwheeling rigidity, but all cogwheeling is tremor plus rigidity. So if you don't have a prominent tremor, you're unlikely to have cogwheeling, but you may, but you move their arm, passively, and may have them make it dead, and you straighten it and you bend it and whatnot, and it should feel dead. If it doesn't, they probably have rigidity. But if you feel it, it feels normal, you can pull it out sometimes by distracting them. So I'll have people tap their opposite hand on their knee as I do the passive movements to try to pull out rigidity. If they have a tremor, so the tremor in Parkinson's disease is a pill rolling tremor, okay? The other thing to note here, it's a resting tremor. It's a tremor that they didn't notice for a long time, but it's only when they're watching TV or when they're have their hand on the steering wheel for a long time, it'll start going. And there's this concept of re-emergent tremor. So they shouldn't or often don't have any tremor with posture. But if you have them put their arms up like this, and I always have people say the months of the year backwards. So they're saying December, November, October, September, and then you'll start to see their tremor come back. And it might just be their thumb goes or these little fingers go. And that is their new resting state. So we call that a re-emergent tremor. So there'll be no tremor. And then all of a sudden, if you sit there long enough, it'll come back, and sometimes it's just their pinky will go, or it's like one finger, okay? And it tends to be slower than the essential tremor. So bradykinesia is slow. So how do you assess slow? I use the movement disorder rating scale. I would not expect anyone who's not specifically in movement disorders to do this, but it starts with finger tapping. So we're looking at big and fast. So sometimes people be like this. And then I'm like, okay, are they slow or are they just not listening? So that I'll encourage people faster, faster, and then do they get really little all of a sudden? So loss of amplitude. So they start big and then they get little and then they get stuck, right? So then now you're so little, you're not even tapping anymore. Then people will recorrect and go down. Okay. So finger tapping, and then I have people do fist palm, fist palm, fist palm. We're looking for either they don't get all the way out again, or they'll get sticky, like okay. And then I have people on their leg, and you can't see my legs, so I'll just do hand in hand, but hand flip flop, flip flop, flip flop. And so people will lose their amplitude, or they won't go all the way over, so they'll only go to here, or they'll just be really slow. Okay, so if they start really slow, but it doesn't get any slower, then I'll just do a lot of, okay, faster, faster, and encourage people, and then they'll, okay, and that's bradykinesia because they're kind of sticky or pausing or jittery. Then I have people do toe tapping, leave their heel on the ground and tap their toes, and then a full stomp, so 10 stomps. I like to do 10 stomps, and this is just kind of my experiences. They can't stop then too. So if they want to do 10, they might do 11, 12, 13. Okay. So that indicates some frontal lobe dysfunction. So bradykinesia, number one. So they have to have either reduced amplitude or pauses and breaks on one or more of these maneuvers. And then you do them on both sides. So sometimes if you say, tap your fingers like this, they'll do this one, which you know, that's cerebellar function, but not necessarily basal ganglia function. So I was just say, oh no, first two fingers. And people need to be coached on this too, because their primary care doctor doesn't do this stuff, right? So you might need to coach them a little bit. And then I have people go like this. I'm like, one at a time, because it's actually easier to do two at a time, but one at a time. Stereotypically, in Parkinson's disease, it's going to be asymmetric. So one side is clearly going to be worse than the other. Okay. Number one, bradykinesia. Number two, rigidity. And if you can't feel that they're passive, if they don't clearly have cogwheeling rigidity, do a distraction maneuver. So have them do 100 - 7, or have them tap on their other knee and still relax to see if they have that subtle resistance to passive movement. Rigidity versus spasticity is something they never, I don't remember learning in NP school, but spasticity, the faster you move it, the faster it pulls back. Rigidity is not dependent on how fast you're moving it. And then once you have bradykinesia and you have tremor, assuming, and possibly even rigidity, then we're like, okay, this is Parkinsonism. Okay. Now we want to see if this is Parkinsonism or if this is Parkinson's disease. Okay. So that's when we start to exclude red flags. There are some absolute exclusions. We want to document any supportive criteria. Do they have that look? Do they have that masked face? Do they have that stoop and shuffle? Do they have REM sleep behavior disorder? Do they have non-motor symptoms? And then time is on your side. So Parkinsonism is a diagnosis. So if you're not sure, you can say you have Parkinsonism. Let's come back and revisit this in 3 or 6 months. Find the bradykinesia. Again, you're looking for a loss in amplitude or pauses and breaks. So I do finger tapping, I do flicks, and then pronation, supination. I do toe taps, I do heel stomps. And I'm looking for them to get stuck, or you can't keep a steady beat, okay? Tremor and rigidity, you need one or both. And then gait instability. So gait instability can be assessed in multiple ways. The first, I just have people cross their arms and stand up out of their chair. And they'll say, oh no, I have bad knees, I have bad hips. And no, they can do it. Okay. So have them cross their arms, get out of the chair. If they're falling back, that is indicative that they have poor postural stability. The other thing I do is what's called a pull test, and I'll have people stand in front of me, and I'll put my knee kind of in between their legs, and I'll pull them backwards, okay? And they should be able to take a step or maybe two and catch their balance. If they are literally falling into you or you're having to push them back up, that's indicative that they have very poor postural stability. Supporting factors, so again, 1, bradykinesia, 2, tremor and or rigidity, 3, gait instability. You might not find gait instability, especially early, okay? The supportive features are those things like stooping of their posture. Their shoulders roll in, they have this masked face, they look like they're mad or sad or bored or pissed off or something. They shuffle their feet, okay? They turn and block, so they literally turn and turn and turn and turn and turn and turn, rather than just flipping around. Sometimes it'll be as subtle as you'll see like one arm with a little bit of a posture when they're walking, or they have reduced arm swing on that side. I've also had people like they kind of hold their arm out when they're walking, like this arm's like this, and then, you know, I had one lady tell me, she's like, I know I've had Parkinson's for several years because I started looking at old pictures, and all of a sudden my hand is like this in every single picture. I never even noticed it. Okay. Resting tremor tends to be very prominent when people are walking. So then you'll start to see their shaking as they're walking. Search for red flags. Eye movement should be normal. Their reflexes should be normal. Their strength should be normal. Their cognition should be normal. If it is not, we are looking at other diseases, okay? Not that people can't have two things at once, but if they can't look up to if you can't see the whites of their eyes when you tell them to look up, that is suspicious. If their saccades are choppy, or if they're having nystagmus when you are doing saccadic testing, that is not normal, okay? People talk about weakness in Parkinson's all the time, but Parkinson's disease does not cause weakness. Deconditioning causes weakness. A lot of things can cause weakness, but people are usually describing that they're slow. They can't get out of the chair, and therefore they're calling it weak, but really that's how they're demonstrating their gait instability and their slowness. So if somebody has severe asymmetric rigidity, so their right arm, literally you cannot pull it straight, or their leg, you can't get it to be straight, I'm very suspicious for cortical basilar syndrome. Again, early frequent falls is suggestive of progressive supranuclear palsy. If they have a litany of autonomic complaints, they're passing out all the time, they get super dizzy when they get up, they can't stand up for more than 10 minutes before they need to sit down, MSA. If they're slow but equal on both sides, I start to think Lewy body or drug induced. Because again, Parkinson's disease starts on one side and then eventually will go to both sides. But if they have symptoms on both sides that are similar, then I'm questioning the diagnosis. In terms of Lewy body, I like to think of Lewy body dementia as a primary memory issue, whereby people will have Parkinsonism, either at or around the same time or later in their disease. I think about Parkinson's disease as a disease of primary movement disorder, that as time goes on, people do develop cognitive disability. So if people have memory issues or prominent visual spatial issues, prominent visual hallucinations early or at around the same time as their tremors started, I'm really suspicious that we're dealing with Lewy body dementia rather than Parkinson's disease. So the textbook differences here. Parkinson's disease, people will come to you and say, my right arm shakes, as opposed to, I can't write anymore, or I can't eat soup. Sometimes people will say I have a right arm tremor because they're right-handed, but when you examine them, it's really actually both. So Parkinson's disease, they will have a tremor when they're resting as opposed to with action. So again, I am examining the patient from the moment I enter the door. Sometimes I kind of sneak out and peek around the corner as my MA is rooming the patient to see, do I see a tremor at rest? Do I see a tremor when they're ambulating? A lot of times people will, put their arms under their armpits or cross their arms or sit on their hands. I will literally ask people, to put their hands on their legs or uncross their arms to help me help them, okay? Postural, kinetic, we talked about resting and re-emergent tremor. Alcohol should not help Parkinson's disease. If anything, it's going to make their postural instability worse. So if they definitely get better with alcohol, that's strongly indicative that we are dealing with essential tremor. Again, as I think I've beat with a dead horse, in essential tremor, we're really dealing with tremor being the problem. And in Parkinson's disease, we're dealing with tremor being a symptom of a much larger problem. And in both, really, we're ruling out red flags. We're ruling out metabolic issues. We're ruling out Wilson's disease, thyroid disease, blood sugar issues, drug-induced issues. Both, what's not so helpful is what both people will report. So both people will report family history of the disease. There is a genetic component to both of these diseases. Tremor always tends to be volatile. If you didn't get good sleep, you have a urinary tract infection, you're nervous to go to lunch with the girls, etc., stressed, fatigued. This is not an age or sex-linked disease, although I tend to start to see people mostly in their 60s and 70s with both diseases. And people complain of handwriting issues in both diseases. However, it's different, the micrographia you see in Parkinson's disease versus the tremor you see in essential tremor. So that's where that Archimedes spiral comes in. Have them write a sentence in cursive, have them write a sentence in with printing. Sometimes you can see that tremor in their handwriting, but also look, are they going up? Are they writing inappropriately small, suggestive of micrographia? I always love for the patients to tell me what they have wrong with them. So I don't suggest complaints. I ask them what's going on. Again, weakness in PD is often postural instability or bradykinesia. People not being able to eat soup is usually tremor. Voice complaints, you can get a voice shaky with either disease, but if they're too quiet or no one can hear me, I'm highly suggestive of PD. Leg cramping, I get a lot of complaints with PD. They're drooling. I ask everybody if they drool during the day, during the night, if they can turn over in bed, if they can get off the chair, if they ever miss the chair, like they sit on the side of the chair versus on the seat, suggestive of visual spatial dysfunction. And if you did all this and you still don't know, that's okay. I give this story, it was Veterans Day, and I just feel so terrible about this, but I walked into the room and this guy looks fine. He looks at my 1 second diagnostic tool said essential tremor. But then, so we did the essential tremor questionnaire and I started examining him, and his rigidity is really subtle and his bradykinesia is really subtle and his gait looks phenomenal. Pull test, gait, sit to stand, all look great. But I'm just sitting here going, oh, this guy, he's complaining of all the right things. Oh, when I hold a cup of coffee, it spills, or when I'm eating the soup, it falls off the spoon. My handwriting is terrible. So I'm thinking, gosh, these are all like ET complaints, but there's just something. It was just nagging me. And then I should have known better. But then at the very end, somehow we got to talking about the Marines. And he was in the Marines at Camp Lejeune. So if you don't know, Camp Lejeune is a Marine base in North Carolina that for decades, from like the 40s to the 80s, they had tainted chemical laced water that over 1 million Marines were exposed to. And actually the federal government is now actually paying people money, I guess, as some sort of consolation prize for getting Parkinson's disease. But it was like, oh, and then I knew just right then and there, he probably has Parkinson's disease. This subtle rigidity, this subtle bradykinesia is probably early Parkinson's disease. So in his case, because he was really hesitant about trying levodopa, we did a DAT scan. And a DAT scan is actually a nuclear medicine scan where we actually can look at the dopamine uptake in the brain. We can look at how your basal ganglia uptakes dopamine. And with early Parkinson's disease, and even any Parkinson's disease, you're going to see a reduction or a deficiency in the amount of dopamine uptake. And especially early, you're going to see one side is definitely worse than the other. Okay, so they'll say, oh, reduced uptake in the left putamen. And that is highly suggestive of Parkinson's disease in these people that you're like, even after all of this, I don't know what I'm dealing with. And then just to complicate it even further, some people have both. You know, this guy had a mom with tremor, an aunt with tremor, a grandma with tremor. Everybody had tremor. He has tremor. It's not really, though, he does have essential tremor, but doesn't appear disabling to me. Anyway, but some people do have both, and that's essential tremor and PD are mixed tremor. Also, people that have had ET forever, decades, they might develop a resting component, and they might also start to look ataxic. Okay, so this brain signaling, we don't really know what exactly causes it. There is definitely a cerebellar component, but if it gets severe enough, they will start to look really uncoordinated. And they will also get some bradykinesia. So you examine this person who you've been following for 10 years for essential tremor, and now all of a sudden they start to look like they're a little Parkinsonian. One, the trick is they might be developing Parkinson's disease too, but also just long-standing essential tremor can start to mimic that bradykinesia and that incoordination that you see in Parkinson's disease. And then when all else fails, you can refer to someone who lives and breathes and dies by tremor. So refer to someone in movement disorders, and they are your best friend in terms of really helping you get the patient's quality of life as good as you can. So that's all I have for you today. Thank you so much. If you do have any questions or concerns, please reach out to the organization and let me know. Otherwise, thank you for your time today, and I hope that this was helpful.